textbooks, dermatology, primary care. Throughout our lives, we will all interact with the healthcare system. So, what happens when that system is not designed with certain groups of people in mind? As a Black person in America, I have experienced firsthand racial disparities in healthcare. The turning point for me came during the pandemic when at a local clinic, I was asked if I had a red rash on my skin. At that point, it dawned on me that some healthcare professionals did not realize that skin rashes do not exhibit the same way on different skin pigmentations. If something so obvious could be so casually overlooked by a healthcare professional, what other elements of care, treatment, research, and education are also being ignored, and what does it mean for people of color using this healthcare system? I am Vivian Kobusingye Birchall, and in this series, we will take a closer look at racial disparities in healthcare, speaking with medical professionals and hearing personal stories to get a better understanding of those disparities and explore ideas and strategies for how to bridge the gaps. Welcome to the show. I'm Vivian Kobusingye Birchall, your host, and my special guest is the Director for the Network Development and Strategic Partnerships for Mass General's Cancer Center. And now this is none other than Miss Evelyn Abayaah Issah. Welcome to the show.
Thank you, Ms. Vivian.
I would like to invite you to just tell us more about yourself and what you do in your own words.
Okay, so I always like to begin about myself by letting people know I'm a mom of two wonderful kids. I'm sure they'll be happy that I remember them. But for my day job, I am the Director for Network Development and Strategic Partnerships at Mass General Cancer Center.
What does that mean?
So that means that I have business strategy, business development, and strategic oversight for our 14 network sites regionally, which includes the hospital next door, MSN, and the cancer programs of those hospitals, by the way. And I have a national relationship with a hospital, and then several international relationships as well. So folks, before I took on this job, I was a director for international advisory services in the cancer center, and I oversaw the development of clinical cancer programs overseas, so in Asia, some Saudi, the UAE, and then our global oncology program in Botswana, Bangladesh, and Uganda.
I also know you're married with, do you want to say something before we get to the next?
Yes, I am married to a wonderful guy called Malik Issa.
There, Malik, I got you. But going back to your work, many people in our community know you just as somebody who served on the school committee, which is not really what we're going to talk about today. But then, you know, the part that I wanted to introduce to the community is somebody, lady who is doing amazing work in our healthcare system, in, you know, hospitals that are serving this local community. So what has that journey been for you? How did you get into healthcare?
So that's an interesting question. My journey into healthcare has been very organic. I know a lot of people don't know, but I'm a trained journalist from Ghana. I actually worked as a journalist before I moved to the United States in 1999 and co-founded a newspaper in Ghana, which is still thriving. So I'm a journalist at heart. When I moved to the United States and I was trying to figure out what to do, it wasn't feasible for me to get back, or at the time, I didn't think it was feasible for me to get back into journalism. So I sort of tried to find another path, and that path took me through the healthcare route. So I actually started my educational journey in the U.S. at Rutgers University, studying computer information systems, believe it or not.
Wow.
And then I met my husband, who convinced me to move to Boston So when I got here, I sort of pivoted and changed my course to study health education. I actually was very interested in public health, but when I enrolled in UMass Lowell at the time, they did not have a public health program. So the closest to that was health education. And then I proceeded to have my degree in health management and policy. That got me into the healthcare realm. And that's how I entered Mass General Hospital with that degree, and then moved through the hospital in different roles until the role that I have now.
Wow, what a journey. And as somebody who is in media right now, sitting right next to you and hearing your journey transitioning from media, you mentioned that you didn't quite, I think, I can't paraphrase, but you didn't see a path in journalism. What were some of the obstacles that you saw that kind of kept you away?
So, so as an immigrant, when you arrive, it's very dizzying and it's very confusing. And I like to say that when you arrive into this country, the people that you come to typically are the folks that lead your path or show you the path you have to take. When I arrived, I did not get a sentiment from anybody that hosted me that it was possible for me to continue my journalism journey here. What I was told is do something that's going to give you a job, do something that's going to put food on the table. You don't have time to experiment. So I didn't even think it was possible for me because that was never put in my head. And I didn't know anywhere to even start looking to get into journalism. So I said, well, the best thing I could do is healthcare. There are hospitals everywhere. And everybody around me, my uncles, my aunts that were guiding me and mentoring me, they were all nurses. And my husband at the time, or my husband now, my fiance at the time, was in healthcare. So the logical step for me was to get into healthcare and not even think about journalism. So I sort of just compartmentalized that in my head and put it somewhere and said, you were a journalist then, not now, just lead a healthcare path. But I have to say that, everything that you do in life always has a connection to what you ultimately do. So my journalism degree comes in very handy in the job that I do because I am a good writer. So, and a lot of what I do is strategic communications, like really talking to CEOs and chairmen and all these higher ups that need really succinct information to be able to make strategic decisions. So that writing ability has come in handy for me. So it's all not lost.
Absolutely. No, the reason I wanted to bring that to highlight that, as my guest on this Women's History Month is to shed light on the journey of an immigrant woman went from, say, the continent of Africa in this case to the United States, and some of what we have to balance or consider when taking on paths. And I think your story just is not isolated. We have many of our immigrant communities that decide to get into certain sectors because that's where the quickest money is, and it's more of survival in that case than and less of a career development.
Correct.
So I'm thankful that you mentioned that. But again, what I've heard from you is that still our skills that we come with later help us, or through the process help us shape our interactions and probably our career goals. So again, that's important to note. But then getting back to your role in healthcare and Mass General, in the Cancer Center, what are some of the trends that you have observed? And maybe to just narrow that down a little bit, what are some of the challenges or inequities that affect women? Let's start there.
So, my job is to build community programs that bring the best cancer care into communities. And I think when I peel that back a little bit to look at what are some of the inequities that women face, I even want to take it broader to say, what are some of the inequities that people of color experience, right? Particularly in the world of oncology. So we know that we're disproportionately disadvantaged when it comes to clinical research. A lot of women of color in Massachusetts have a higher incidence of breast cancer.
I didn't know
And they do not have the same, most of them do not have the same treatments that a white woman would get, or access to the same treatment as a white woman, a non-white woman, a non-black woman would get, right? So whether we're talking about access as it pertains to people of color or access just for a narrow group of people, women, there is disparity in care, in cancer care. So in my hospital, for instance, one of the efforts that we are embarking on is getting people of color to have access to the novel therapies that we have at Mass General Cancer Center, right? CAR T cells, immunotherapy, all these novel programs that we have that people necessarily do not have access to. So right down the road from Mass General, women do not have access to the same care that a white woman would get in Mass General Cancer Center. So that to me is problematic. I co-chair our Equity Council, and part of that effort we're organized into 3 groups. One is just focusing on community access, making sure that people know that this is the place to come to, this is the care you can get when you are able to come here, advocating for payers to fund people to be able to come there, because not everybody's insurance is received everywhere. So that's one aspect. The other thing is clinical trials, encouraging people to enter phase 1 clinical trials. We all know oncology care has evolved so much that phase 1 clinical trials are now almost considered standard of care. Because sometimes it's not just your best shot at the best outcome, it is the only best shot you have. And not everybody has access to that. And cancer treatment is evolving so quickly that we still have hospitals that are still stuck in like therapies that are not novel, like targeted therapies, when people are moving to CAR T cells, right? So just having access, opening up access for people, making sure that people have the cancer care close to their communities, that they can access it, they necessarily don't have to come to Boston to be able to access that. Mass General Cancer Center recently opened an early detection center in Waltham. Now, payers are not paying for that, but if you want to check to see if you have cancer or whether you have a primary unknown, you can now go get a blood test that can tell you whether you have anything that you should be worried about. That's still an access issue. Not everybody can be able to afford that, because right now you're paying out of pocket and it's not covered fully by insurance. But these are some of the programs that I hope that in my role as a director of network development, that I can bring these programs closer to people's homes, that I'll make access available to everyone so that people can get the best cancer clinical care in their neighborhoods without going to maybe, say, an academic medical center to be able to access that.
Now, you mentioned something very important. The statistic that breast cancer, disproportionately affects Black women in this country because of the maybe even limited access to diagnosis and all that. And
early detection.
Early detection. So, and of course, you've mentioned that one service now that is available in Waltham, but it's still out of pocket, right?
Yeah.
So, where are the other centers that Black women can go to try and get tested? Especially those that don't have good insurance, because it is a challenge.
It is a challenge. I mean, the one thing that I would say is that every woman should try and get every woman 40 and above should try and get a mammogram, right? That is one of the best ways to detect if you have breast cancer. Most people or most women of color who do not have access to insurance probably don't get their yearly routine breast exams. I know that we have imaging centers in Waltham. We have imaging centers. I know Emerson has an imaging center. We have Newton Wellesley. Wentworth Douglas, Danvers Hospital, Cooler Dickinson Hospital. So we have our cancer centers all around. But in terms of Greater Boston, I know Dana-Farber has their own spaces as well, but we have Boston Medical that also have places that people can go and get imaging. I think that I have to say that when you're getting your breast exam, wherever you can get in to get that mammogram, you should get it, because if your breast cancer is detected early, you have a very high chance of getting cured, almost, of it.
Right.
And living a full life.
Right. And, you mentioned mammograms. I really have to share this story so that the community can know about some of the challenges with our healthcare system. Through my personal experience, about 2 weeks ago, I went for the annual mammogram checks at Emerson the Hummel Breast Cancer Center. Yeah. And then when we were waiting in the waiting room with some ladies, we're talking about how to schedule. And then the lady, was sharing how she got a reminder for the appointment. And I said, oh, you do get reminders? I have never got a reminder for such a, I rely on my calendar. And she said, no, I got 2 reminders. And I said, it shocked me. I said, how is that possible? We got none. The only communication I get from this center is a letter to my address asking me to schedule. And that is the only interaction I get with this center. And God forbid if I moved from that apartment and never received that letter, then I would have to find other means of contacting this center. So after the appointment, I went to the reception area and I asked the lady whether they send out reminders to patients. And she looked at me, she said, yes, we do. I said, but I never receive reminders. And then she said, well, we do it for some patients. I said, I asked what the criteria was. And she said she didn't know what the criteria was, but their system somehow might be faulty, but it only sends reminders to some people and not others. So if you're listening, Hummel, the Breast Cancer Center at Emerson, this is terribly disturbing. As someone in healthcare,
I'm happy to take that back and try to look into that. The only thing I can think about is if maybe they have like a patient portal that patients should be signing into, and that way you are getting your reminders. But I will look into that, because everybody who has ever had a mammogram, I can speak to the details of the system because I'm not in the weeds like that. So I don't know what exactly the fault is, but I'll look into it and let them know that there's certain patients that are not receiving reminders. But what you say is very important, because we're so busy in our lives, right? If there's not an easy way that patients can be reminded that your annual mammogram is due, your colonoscopy is due, your prostate check is due, people just don't remember. They just keeping on moving. When COVID hit, I totally forgot I had not had my physical for 2 years. Yeah, because and I'm somebody that's always on top of my healthcare, and I go for my annual physical every year. But last year was when I realized, wow, I have not had my physical for 2 years. So when you don't have those reminders, it's part of the decision support tools, right? They're helping you make the decision. So I apologize that you have not getting your reminders, but we'll look into it and try to fix that.
I know, and I mean, if it was just me, what startled me the most is that the receptionist was aware that there is a group of people who receive and others who do not, but did not know what the criteria was. And so I was concerned, and I figured I would get one opportunity to actually raise this because other people might not have the opportunity to do this. So thank you for offering to take a look at this.
I'll look into it.
Didn't mean to hijack but I mean, we're talking about healthcare blind spots.
Yes.
These are the blind spots that we need to address because they affect care.
They do.
So back to your journey and the trends globally. I know that you have worked not only in the United States, but also outside of the United States. What are some of the similarities in the kind of care or challenges or disparities? I won't limit you to whatever trend that you'd like to share.
So in terms of cancer trends, the 5 top tumor sites are global. Like in the US, it's breast cancer, GI, thoracic, GU, and GYN. Usually anywhere in the world you go, those are the 5 top cancers, right? Whichever takes number 1, number 2 will sort of like move, but those are usually the 5 top cancers. So I bring that up because it's a global world. We're all experiencing the same trends. Now, in the US, most people have access to better cancer treatment than in other parts of the world that I have seen. So when we first entered China, for instance, and building our hospital in Shanghai, there was no immunotherapies in China. There was no immunotherapies.
Wow.
They had 25 targeted therapies. We had already taken that leap and using immunotherapies for years, right? So which meant that patients in the US were getting a better shot. This was before CAR T cells even emerged, right? So by the time we were leaving, our contract was almost done with our Shanghai project. We're leaving, 2 immunotherapies had entered China, Keytruda and Aptiva, which actually changed the game in how cancer care was provided, right? So you're looking at China, come to Africa. Let's take any part of Africa. I don't know many African countries and don't know the details of the cancer, but I can almost assure you that not too many African countries have immunotherapies as we're speaking right now. And I'm not even sure that they have all the targeted therapies that we have in this country. So you can see why our families are dying back at home, because the trends are the same. We know how to care for these patients in all of these tumor sites. The science is evolving, but the science is not evolving and it's not catching up with low and mid-income countries in the way that it is evolving here. I don't think that I know of any African country as we speak right now that is doing CAR T cells. And we know that CAR T cells is one of the ways to cure cancer now. People come in metastatic, they're giving this treatment, and they walk out cancer-free, and they're living and they're thriving. And I might have access, you might have access, but I don't think there's any relative of ours that is anywhere on the continent that can have access unless they have $1.5 million in their pocket to come to the US and access that care.
Which are usually the elite politicians and all that who can, yeah, I won't get into that. But no, but that's, again, very disturbing. I mean, I have been, as you may know, I've been part of the Global Health Calypso following their work in terms of trying to improve access to some good treatments on the continent of Africa, and you yourself have had projects in Uganda, and so just hearing you say this, it's just alarming and sad, because our families are back there. All my siblings are in Uganda, but what can be done what are some of the steps that can be done to improve this, to break these disparities?
I think that global access to care is important. Mm-hmm. It's something that we all have to propagate. So the work that you guys are all doing with the Global Health Catholics, right?
Yeah.
That project is huge. I was actually looking at the link you posted yesterday and all the players, and my radiation oncology chief is actually there, Anthony Zeltman. So I was like, yeah, we have mass general representation here.
Yes.
But the point I'm making is that we have to be intentional about building global access to care, or global healthcare access, however we want to say it, because it's the disparities and the disproportion in the way care is provided globally is disturbing. There's no reason why in 2023 that a certain group of people have better care than other people. The pandemic has taught us that healthcare is very global, and that if we do not intentionally build these healthcare systems and access that are global, that anything that happens in that small country, Ghana, could probably get us here too, right? Because of the way people move, because of the way we are interacting. That diseases move the same way. And so I'm saying all that to say that each one of us have a role. I mean, I constantly think about the programs I build. How can I build those programs back at home? Like, who can I work with in Ghana, in Africa, any part of Africa to build these programs? Because I know that if any African country were to have a comprehensive cancer center, that would give any African the best shot at the best outcome. The people will get, that person will get on a plane and go. It doesn't mean matter if it's in Uganda, it's in Kenya, it's in Nairobi, wherever, Accra, Lagos, wherever, people will go.
Yeah.
We don't have that one cancer center in Africa that I can point to and say, wow, my family member cannot get to the US, but they can get to Nigeria. My family member cannot get to London, but they can get to Uganda. We don't have anything like that. And so I think there are a lot of us in these programs and who are working to build health systems, and we have to have a concerted effort, come together and be intentional about the way we develop these programs or how we nudge our institutions and force them to help us build something back at home for our people.
Yeah, and with that, I just wanted to acknowledge President Biden's administration that is really putting in a lot of commitment to expand the Cancer Moonshot goals on the continent of Africa. It's not, it takes some of that public commitment at a very high level for, I think, the rest of the community to pay attention. And so I'm really, really grateful for the whole Cancer Moonshot team at the White House. Thank you so much. We'll be bringing more about, some of these commitments being made in the coming few months. But for now, coming back to your work locally, having observed some of these challenges, what are some of the, not observations, but recommendations you have for our healthcare, for we the users, first of all, of healthcare, and the providers of healthcare?
I will start with users. I think that, and
I should have said consumers.
My life is surrounded with oncology all the time, so that's always my point of reference. What I say that to say, get your preventative care. Early detection in cancer is key. If you're gonna get the best shot at, a cure, your cancer needs to be detected early. And the way to do that is to ensure that you're getting your mammogram, your colonoscopy, your prostate checks, all your early screenings and early detection tests so that people know. I'm hoping that, with all this early detection center that Mass General Cancer Center has opened at Waltham, that it's scalable, that we can scale it across all of our community sites as well, or maybe the payers will pay so that people can go and have these tests if they qualify. There's a criteria. You just can't walk in and say, I want an early detection test and get it. You have to meet a certain threshold and criteria, but access is a problem. People need to be able to pay for it. And if we can scale it to other places, people who are in Wentworth, Douglas, and can get to Waltham can have it at their site. So that's one thing, encouraging users to go and seek their primary preventative care. And for providers, as a person of color, what I always say is that you are an effective provider if you have cultural humility.
I love that.
Cultural humility is something that we lack in healthcare. Most providers tend to think that they know what people need and they know their needs without factoring in what their cultural needs are, and that's how people are not compliant. So being culturally humble and understanding that I am a Ghanaian, I will eat my fufu. If you tell me to lose weight, I will eat my fufu. So how do you factor in my fufu and groundnut soup into my weight loss journey, right? And for a provider to yell at me and say, well, I've told you to cut all the carbs and this and that, without really understanding the cultural stuff that allows me or prevents me from being compliant is problematic. And I think that a lot of providers are realizing that there's a difference between cultural competence and cultural humility. A provider might be culturally competent, they know about my culture, they understand my culture, but they're not humble to my culture. And humility means that they're accepting my culture for who I am and factoring that into my healthcare journey. Because it's a collaborative decision-making process. Absolutely. Healthcare is not my doctor telling me what to do. It is how do we achieve my goals together. And because the demographic of this country is changing, there are a lot of people coming into America. Providers need to start looking like the changing demographic, which is very important. When I say providers, I just don't mean doctors, PT people, OT, nurses, aides, anybody that's providing healthcare, the person checking people in. Everybody that is providing healthcare should look like our changing demographic. I know that's going to take us time to get there. But for what we have now, we need to incorporate cultural humility training into our medical school curriculum, into our nursing curriculum, into our physical therapy curriculum, to our OT curriculum, all the disciplines, so that people understand that being culturally humble actually provides good health and gives patients good health outcomes.
Right. No, it's interesting that you kind of distinguish between cultural humility and cultural competence. So I did in 2021 a small cultural competence training for the perinatal unit, and also because of this conflict between culture and services and healthcare services, and especially for new mothers, like that we come with our culture systems for maternal health, where the whole community is involved, and the hospital expects the woman to just be independent and not dependent on other people. So anyway, we were addressing those, but what you're pointing out is that it's not just enough to be aware of these differences, but to actually embrace these differences and become partners with the patient to try and find a holistic approach that works.
Yes. Correct.
So this is great, and also I appreciate that you mentioned other providers like therapists and all that. So I had to go to PT at some point, and some of I kind of joked about it, but some of the exercises they were giving me were to read certain to say what was on a picture, just to measure my competence, whether I can actually, my brain is actually working or not. But I told these people, these are all foreign objects. I don't have them in my culture. I've never seen them. I'm seeing them for the first time. So how do you measure whether it's my lack of, my brain is not working, or I just don't know the object?
Yes.
So, and then we would joke about that. But, in more serious, if it hinders progress or treatment, because it's not, effectively measuring the progress of the patient, because
Correct.
We're using the wrong tools. Is there anything that we haven't mentioned about you, your journey, your work in Mass General that you'd like our viewers to know?
Not really, other than to add that, particularly for your non-white viewers, that I recently gave a talk to newly arriving foreign professionals, and they had me down on the agenda as a successful immigrant, which was funny because I don't know what that even means, a successful immigrant, but all right, I embrace it. But what I shared was that coming to America as an immigrant is a journey. It's a marathon, it's not a race. I have worked every job. I have worked as an aide, I've worked in a group home, I've worked in a day program, I've worked live-in, I have been a staff assistant. So I just didn't come to this country to be the director for network development and strategic partnership. No, it was a journey. That journey took many years, right? Every job that I've held in this country have added to my toolkit that I use today. So, people see a woman of color and they think, oh, it came easy. No, it didn't. I worked my behind off. I was intentional about where I wanted to get to, what I wanted, and I pursued it. So if anybody is listening, is new to the country, and is wondering, oh my God, did I make a mistake? Why am I here? Oh, I had my cushy job back in my home country. I left it and I'm here. I'm never going to make it. No, you will. It just takes a while.
Amen.
And patience, but you will. Just be intentional about it and do it. And just keep focused and you'll get there.
No, thank you so much, Miss Evelyn Abayaah Issah. I have to remember to say the Issah. I learned my lesson. But yeah, it's been great having you here. Thank you for making the time to speak with me.
Of course. Thank you for having me. And it was a pleasure speaking to you, sharing my journey, and talking a little bit about cancer, which is my bread and butter. And I don't mean people getting cancer, but I mean setting up programs so people do not have, or people who have cancer get the best care, or reminding people that you need to go and get your screenings for early detection. And then talking about Africa and how we can set up these same programs in Africa. And thanks for all the work that you do with the Global Catalyst and program and all the great work you're doing in the continent, because it's important work.
Oh, thank you so much. Let's say local health is global health and global health is local health. And, we have to keep holding hands. And so we work this journey together. And especially also in our local community here in Acton, there are still disparities that affect our people here through the most convenient healthcare providers, are predominantly non-Black. So we will continue having these conversations so that we can make a difference in any way that we can. So again, thank you for being here. And to our viewers, thank you for watching. Till next time.